I remember sitting in my car after receiving my grade on the anatomy exam. The grade wasn't terrible, but it wasn't what I expected, especially after the hours I spent studying. And instead of thinking, okay, I'll just adjust my studies. I remember sitting in my car after receiving my grade on the anatomy exam. The grade wasn't terrible, but it wasn't what I expected, especially after the hours I spent studying. And instead of thinking, okay, I'll just adjust my study strategy, I thought, maybe I'm not cut out for this. Not PA school, not healthcare, not this path. And the scary part, it wasn't the exam. It was the exhaustion. I was juggling classes, patient care hours, volunteering, and applications, constantly comparing myself to others who seemed to be doing more. I wasn't even in PA school yet, but I was already burnt out, and I didn't have the words to describe it. What if burnout doesn't start in PA school? What if it starts before healthcare training even begins? Pre-PA students juggle academics, patient care hours, applications, financial stress, and constant comparison. Many are already exhausted before PA school even begins. And yet, we call it ambition, we call it drive, we call it paying your dues. But what if we're normalizing burnout before students ever enter the profession? Because burnout doesn't suddenly appear in PA school. Burnout often begins early, but support comes later. Students report high stress and imposter syndrome, isolation, pressure to compete, and limited coping resources. When burnout goes unaddressed, it doesn't just affect grades. It affects confidence, motivation, persistence, and sometimes whether students even apply at all. That's why we focused on pre-PA students in the USC PA Pathways program, motivated, high-achieving students who are deeply committed to healthcare but often silently overwhelmed. If we want to protect the future healthcare workforce, we have to start earlier. Mental health struggles in pre-health spaces are often normalized as part of the process. If you're tired, you're working hard. If you're stressed, you care enough. If you're overwhelmed, you're competitive. But burnout isn't just stress, it's emotional exhaustion. It's detachment from a career you once felt passionate about. It's questioning your ability, not because you lack potential, but because you lack support. Burnout can lead to decreased performance and, in some cases, attrition from healthcare pathways altogether. When we lose students before they even enter PA school, it stops being a student issue. It becomes a workforce issue. It becomes a public health issue, which raises an important question. What does the research actually show?
So, what does the research actually show? Burnout doesn't suddenly appear in PA school. It starts much earlier. In fact, studies show it can begin during pre health training driven by things like workload, pressure to perform, and a lack of structured support. At the same time, many students aren't using formal counseling services, not because they don't need help, but because of stigma, time constraints, or fear of seeming weak in a competitive environment. But there's good news. Research consistently shows that peer based group interventions work. When students hear from people who've recently been in their shoes, something shifts. Trust increases, stigma decreases, and people are more willing to engage. That's what guided our approach. We pulled from Healthy People 2030, community mental health data, and existing burnout literature. And the message was clear. If we want to prevent burnout, we have to start early and we have to make support feel relatable. So that's so based on that, we designed a peer-led lunch and learn for pre-PA students in the USC Pathways program. As third-year PA students, we've recently gone through this process ourselves, so we're not just presenting information, we're sharing lived experience. We started with a quick pre-survey to understand where students were, their stress levels, awareness of burnout, and sense of support. From there, we shifted into a conversation. We talked about imposter syndrome, common stressors, and what burnout can actually look like during the pre-PA journey, while also sharing some of our own experiences. Then we paused. We gave students time to reflect, to think about their own stressors and whether they were already noticing signs of burnout. They discussed in small groups, which was powerful, helping them realize they weren't the only ones feeling this way. And that shift from isolation to shared experience is huge. From there, we focused on action. We introduced simple, practical strategies and then guided students through creating one SMART goal that they could realistically implement. Because awareness alone doesn't prevent burnout, structure does. By the end, every student left with one concrete step, and we closed with a post survey to measure what actually changed. So this wasn't just a discussion, it was a structured, measurable intervention. So, why does this approach work? First, reliability. When students hear from peers who've recently navigated the same challenges, the message feels more real and more attainable. It lowers barriers and opens the door for honesty. Second, normalization. Hearing others talk about stress or imposter syndrome helps students realize that they're not alone and that alone can reduce a lot of internal pressure. Third, reflection. We built in time for students to actually pause and think about their own experiences, and that self awareness is the first step towards change. And finally, structure. We didn't just talk about burnout, we gave students a way to act on it. SMART goals turn into intention into behavior. All of this aligns with the social cognitive theory, especially the idea that seeing someone similar to you succeed increases your own belief that you can too. So when you combine reliability, reflection, and action, you create something that is not just informative, but actually impactful.
Health literacy was a key consideration in how we structured this intervention. Burnout's often discussed using clinical or academic language, but we intentionally avoided jargon. We used simple, accessible language that pre-PA students could immediately understand and relate to. Instead of abstract definitions, we used real-life examples, academic setbacks, comparisons, time pressure, situations students are actively navigating. We also incorporated interactive reflection activities. Students weren't just listening, they were identifying their own stress patterns and early warning signs. We included practical time management exercise and SMART goal planning so that students could translate awareness into action. Health literacy is not just about understanding a concept, it's about being able to apply it in real life. By the end of the session, students didn't just learn what burnout is, they learned how to recognize it in themselves and what to do about it. By reducing cognitive load and avoiding academic jargon, we increased accessibility and comprehension, which likely contributed to the measurable improvements observed in the post-test knowledge scores. But clear communication alone isn't enough. It also has to be culturally responsive and equitable. Before we implemented trauma-informed strategies, we grounded our intervention in cultural humility and equity. Pre-PA students represent diverse cultural, racial, socioeconomic, and educational backgrounds. Their experiences are not all the same. Some students are first generation, some balance full-time work while completing clinical hours, some carry financial pressures or family expectations that shape how they experience stress. Cultural humility means recognizing that we as facilitators do not assume we fully understand every student's lived experience. Instead of prescribing one correct way to manage burnout, we encourage students to identify strategies that align with their own realities and responsibilities. Equity influenced how we structured the intervention. It was free, accessible, and sponsored by an existing funded program and required no additional financial resources. We emphasized low-cost, realistic coping strategies rather than solutions that assumed access to therapy, flexible schedules, or external support systems. If support requires privilege, it isn't equitable. We also intentionally incorporated trauma-informed principles into our intervention. A trauma-informed approach recognizes that burnout does not exist in isolation. We avoided language that implied weakness or failure and instead normalized stress as a common human response to high expectations. By sharing our own personal experiences, we modeled vulnerability, which reduced stigma and helped create an environment where students felt seen rather than judged. Rather than telling students what they were doing was wrong, we provided tools and allowed them to identify strategies that aligned with their individual circumstances. Trauma-informed practice is not about eliminating stress, but creating supportive environments where students feel safe enough to address it.
Effective communication was central to the success of this intervention. We intentionally used storytelling as a strategy. Personal narratives reduce hierarchy and make difficult topics like burnout feel approachable rather than clinical. We incorporated interactive discussion and reflection rather than a lecture format. Students weren't passive recipients of this information. Instead, they were active participants in the conversation. We also used scenario-based examples that mirrored real-life pre-PA stressors so that they could see themselves in this context. Beyond communication, this intervention also serves as advocacy. By openly discussing burnout in a pre-PA space, we challenge the normalization of overwork and silent suffering in healthcare pathways. Advocacy in this context means elevating student voices, promoting early wellness support, and not waiting until students are already in crisis. If we normalize conversations about mental health before professional training begins, we shift the culture of healthcare itself. Burnout should not be a rite of passage. Our pre-intervention data demonstrates a clear need for early burnout prevention. As shown on the graph to the left, 96% of the participants reported having personally experienced burnout prior to the session, which indicates an already prevalent amount of burnout among pre-PA students before even entering professional training. Additionally, we asked how often they feel tired or exhausted from those pre-PA obligations. The majority reported feeling moderately to frequently exhausted. This reflects sustained emotional and physical strain rather than occasional stress. When asked to list signs and causes of burnout, they noted things such as fatigue, brain fog, anxiety, and loss of motivation, and contributing factors like high workload, financial stress, and lack of support. While students demonstrated awareness of burnout, their coping strategies were limited and inconsistent. This gap between awareness and structured prevention informed the design of our intervention. And then the post-intervention results reflect a response of about 15 participants. The comparison graph shows an increase in the student's ability to correctly identify 3 signs of burnout from pre to post test, indicating a measurable knowledge gain. Additionally, 100% of participants reported understanding the causes of burnout in pre-PA students, as indicated by strongly or somewhat agreeing. Most importantly, all participants created at least one actionable SMART personal goal. This demonstrated that the intervention translated awareness into behavioral readiness. These findings suggested that a peer-led structural burnout prevention session can improve both knowledge and action-oriented coping in pre-PA students.
In addition to quantitative improvements, we analyzed open-ended responses from the pre-assessment. The themes reflect emotional exhaustion and reduced motivation, both components of burnout. When we look at a measurable change, we see significant improvement. Correct identification of 3 signs of burnout increased from 40% pre-intervention to 86.7% post-intervention. Using a McNamara exact test, the increase was statistically significant with a p-value of 0.016. This suggests the improvement was unlikely due to chance. We also examined behavioral readiness. Before the session, only 11% of students were able to identify at least 2 structured SMART action steps to reduce burnout. After the intervention, 100% of students were able to create at least 2 actionable SMART goals. Students didn't just understand burnout better, they left with a concrete plan to address it. Our post-intervention results demonstrate a measurable improvement aligned with our objectives. First, 100% of participants reported understanding the causes of burnout in pre-PA students, indicating improved knowledge and conceptual clarity. Second, every participant created at least one SMART personal action step. This reflects behavioral readiness, not just awareness. These findings suggest the intervention successfully translated education into structured action. While our sample size was smaller, the consistency of positive outcomes support the feasibility of peer-led early burnout prevention within pre-health populations. However, these results are based on short-term self-reported data collected immediately following the intervention. We didn't measure long-term adherence to SMART goals or sustained mental health outcomes, which limits our ability to determine lasting behavioral change. First, we had limited time. Since the session was only 1 hour, because of this, we focused only on the most impactful strategies. We also had a small sample size. Since the intervention took place during the Pathways event, so the results may not represent all pre-PA students. Another challenge was that the students may hesitate to openly discuss stress or burnout in a group setting. Additionally, students had competing priorities during the event, including other sessions and networking opportunities. Finally, our intervention focused on one group rather than multiple organizations, which limited the range of perspectives. To address these barriers, we used anonymous QR surveys, focused on 2 to 3 high-yield coping strategies, and encouraged openness by having PA students share personal experiences with burnout. We also proposed a Zoom session to expand the intervention and reach more students.
To ensure long-term impact and sustainability, we could train future PA cohorts to deliver the workshop so it continues after our group graduates. We could also expand it to other undergraduate campuses to reach more pre-PA students experiencing stress and burnout. Offering Zoom versions would make it easier to scale and allow students from different schools to participate. Additionally, partnering with PA alumni could provide mentorship and shared experiences with burnout. Finally, integrating the workshop into PA program orientation, introduce coping strategies and burnout awareness early in training. As we conclude, we want to highlight two strengths of this project and one opportunity for growth. First, the most powerful aspect was peer connection. Students trusted the message because it came from individuals who had personally navigated the pre-PA process. That relatability reduced stigma, increased openness, and contributed to 100% post-session agreement that they understood that causes of burnout. Second, this intervention translated awareness into action. Rather than stopping at education, every participant created at least one smart actionable goal demonstrating behavioral readiness, not just knowledge acquisition. This bridge between understanding burnout and actively planning prevention is where meaningful changes begin. In terms of growth, while short-term outcomes were strong, a key opportunity is long-term follow-up. Tracking with whether students maintain their SMART goals and coping strategies would help evaluate sustained behavioral and mental health impact. Ultimately, burnout prevention in healthcare must begin before professional training, and peer-led, structured, accessible interventions like this offer a scalable model for early prevention. At the beginning of this talk, we shared a moment of doubt, a moment where exhaustion felt heavier than ambition. That moment doesn't mean someone is incapable. It means they're human. Burnout should not be the entry fee into healthcare. If we want resilient providers, we must protect them before the system begins to wear them down. Prevention doesn't start in PA school. It starts here. It starts with conversations. It starts with peer support. It starts with early intervention. And it starts with us. Thank you.